Okay, so I'm going to pick up really quick here and fill in some information on postpartum hemorrhage for you guys. So let me go ahead and share my screen. Okay. So when we're talking about postpartum hemorrhage, we're talking about anything immediate within that kind of first 24 hours. Again, when we're talking, and that's where I want you to think immediately. When you are thinking about other things, when you're thinking about late postpartum hemorrhage, that falls into a different classification. So again, just remember, you have your 500 mils of blood after a vaginal birth, your 1,000 after a cesarean. Those are kind of your thresholds. You can have up to a 10% loss or change between with your hematocrit between labor and your postpartum period and still be considered fine. Anything at that 10% level again or greater is going to also be defined as a hemorrhage. So we are then talk about those classifications, either early, acute, or primary. You might hear it used different ways. Really, that's going to be within that first 24 hours of delivery. And then late or secondary, you can still have postpartum hemorrhage after that 24 hours, but usually by that 6 weeks postpartum, that's when you're considered to kind of be at the end of that postpartum hemorrhage protocol. So when we're looking, we have about 4 main causes, and it falls into this nice little acronym here. We've got our 4 T's. We've got uterine atony, referring to the uterine tone. Tissue, so again, we're looking at retained tissue. So like your retained placenta. Trauma would refer to those lacerations. Think about lacerations that you can't see. Remember those hidden lacerations, your cervical, your vaginal lacerations, and thrombin. Thrombin is kind of down on the bottom of the list. Not too many hemorrhages would occur here, but still considering, you do need to consider that in your differential diagnosis. So thrombin here is referring to any kind of anticoagulation or coagulation disorder. So your factor fives, that kind of thing would fall into here. So let's go and talk about these classifications just a little bit more in depth. So first, when we're talking about early postpartum hemorrhage, one thing might be related to the placenta. So again, remember how we have actually talked about how you shouldn't pull, the provider shouldn't pull on that umbilical cord, because doing so might actually cause that uterus, or excuse me, that placenta to actually like pull apart and have kind of that incomplete pulling apart or separation from the uterine wall, the endometrium. So this causes like undue manipulation of the fundus, and then creates or can lead to an incomplete separation of that placenta, which then goes into the whole retained products kind of a deal. But basically, remember again that provider should just be waiting for that placenta to detach naturally. Uterine atony, this is a big one. So this is referring to the hypotonic state of the uterus, and that in itself can cause a postpartum hemorrhage. So remember again, when we referred to this in our discussion last week, we talked about how that polyhydramnios, that macrosomic fetus, the high parity, the multifetal gestation, how that really stretches out that uterus. And then the uterus has a much more difficult time after this kind of a situation to have that subinvolution process and contract back down to that normal state. And at the same time, also contracting and putting pressure upon those tiny bleeding little vesicles there that would have previously attached the placenta to the uterus. So then what happens is the uterus, as you can see here down in this bottom right picture, without that contracting process, we have this hypotonic state and it leads to hemorrhage. So then there's this other disorder. Well, we'll get into that in just a second. So retained placenta. So after 30 minutes, if we cannot get a placenta out, we'll go ahead and manually go in and remove that. Um, this would be a very painful procedure. This would be a very difficult procedure, but one that would need to be done. So the patient, your postpartum patient, should be medically put under pain medication, perhaps even some general anesthesia if we have an epidural in place, really continuing to medicate that woman. We might do a DNC or section DNC, go in and do that dilatation and culturage and actually remove the placenta. Failure to do so, if we were to go ahead and allow that placenta to continue to be remained within the body, you would see a uterus that is going to continue to contract. We obviously have a high rate of infection. There's a lot of concerns. That uterus cannot clamp down significantly and begin that subinvolution process. So we have to get that placenta out. Then we have this really odd, but not unheard of kind of disorder that might happen. If we cannot, again, this goes back to not per se like pulling on that umbilical cord, pulling on that placenta without knowing what you're looking at. This disorder with the accreta, increta, and percreta is typically seen on ultrasound. So what you have here is the placenta actually growing into the myometrium or the endometrium, different layers of the uterine musculature itself. So what we have here causing this is some defective endometrium at the site of implantation. And then the placenta actually grows into the musculature, as I mentioned. So accreta is a little bit, increta, as you can tell from the picture, is more of a deep penetration, and the placenta percreta goes completely through the uterine wall. Obviously, we're not going to be able to remove this placenta without creating a large laceration, large hemorrhage risk, etc. So in this case, this delivery is going to be followed by a complete, or by a hysterectomy, a uterine hysterectomy. When you have a placenta percreta, it has not been unheard of to have that percreta grow into and actually extend out of the uterus and into bowel or bladder tissue. So that kind of hysterectomy and that labor is actually going to have to be performed in probably a general OR versus the OB labor delivery ORs that you guys have. So this one was going to have to be attended by more than likely a general surgeon to help remove some of that adhered tissue from the placenta. Because again, what is going to happen if we have any placental tissue anywhere within the body? Okay, it's going to continue to release hormone. So it needs to go. We also need to talk about lacerations. So we can have a laceration, again, as you guys are aware, of the cervix and the perineum. We might have a slow trinkle or a large hemorrhage with these lacerations. Again, goes back to the importance of doing a complete and thorough and frequent, every 4 hours or so, perineal check for any kind of laceration following a vaginal delivery or an attempted vaginal delivery. So earlier when we talked about hematomas, way back when I introduced you to them in Unit 1, we talked about a small labial hematoma. And with a small labial hematoma, we would encourage that ice and analgesics. Well, you can also have a very large labial hematoma. And obviously here we have more of a bleeding into the tissue itself. This might be in the vulva. It can also be in the vaginal area as well. Surgical evacuation might be necessary for this removal. And basically, I mean, the blood is just coming right into this labia. And if you can imagine, that's going to be very uncomfortable. This again goes back to your assessments. You need to be palpating if you're concerned at all about those labia. If you notice when it's starting to get enlarged, engorged, discolored, palpating, is it soft or is it hard? If it's soft, obviously that's going to be a better sign than versus a hard. Hard is going to indicate that your tissue is just fully saturated with blood. We're going to go ahead and put ice packs to that perineum 24 hours postpartum to try to prevent this from happening. But if it does occur, you're going to have to get your obstetric or gynecologist in to take a peek at that. So a complete uterine inversion, this is where the uterus actually comes out of the vagina. It's potentially life-threatening. It occurs 1 in 2,500 deliveries. So this actually happened to one of my friends, and she, it was her first delivery. She had a very large baby. It was larger than what anticipated. No previous risk factors. She has gone on to have 2 more children. They have all just been these large babies. But obviously now they don't let her go to term. So Michelle gave birth to her baby, and then what came out with her baby was her uterus, just completely flipped out. And so she said, and this is when I was working in peds with her, she said, here I am laying here, my legs all up, I'm completely exposed, my uterus is literally hanging out. And the first and second year residents that we worked with on peds had been called to delivery. So they're in the delivery room. She said, well, they're trying to manually push my uterus back up into the, abdominal cavity. So you can have a complete or incomplete. So symptoms here are obviously going to be hemorrhage. This fundus, you're not going to be able to palpate. Why? Because the fundus is out, right? The uterus is out. You can't feel the fundus. So what we're going to try to do is we're going to go ahead and administer tocolytics to this woman to kind of encourage that uterus to relax. We need it to not contract. Like, this is the time not to be contracting, preventing hemorrhage. Isn't that crazy? This is your weird one. And then the practitioner will manually replace that uterus. This is also the uterus after delivery that you are not going to palpate that fundus, okay? Because obviously this woman is at large risk of having this uterine inversion. Yeah. And you do not want to be responsible for that. So again, this is, the importance of getting a thorough patient history. So late postpartum hemorrhage. So again, remember, this is after your 24 hours past delivery. This is up to your 6 weeks postpartum. You can end up with issues related to those retained products of conception, or otherwise known as retained placental fragments. And then you can also have concerns related to pelvic infection that would cause this bleeding. And this would obviously discourage that subinvolution process. Okay, so now we know the risk factors. What happens if it actually occurs? What are we going to do? Well, early recognition and treatment is crucial for the patient's survival and for the best outcomes. The initial and first intervention, except for when we have, your complete uterus inversion, is to do that firm fundal massage. We're going to try to express any clots that might be in that uterus. We're going to try to get them out. And then elimination of bladder distension. So we're going to put a Foley catheter in place. You don't think around. This is not a time to be putting a patient on a bedpan. You need to have a very accurate intake and output amount on this patient. Because as you guys know, when patients start to crash, you're going to see indications of that on multiple levels, and having that accurate INO is going to be key. We're going to do a continuous infusion of 10 to 40 units of oxytocin added to your 1,000 ml IV fluid. So you're going to be running your pit, probably full open wide on your channel. So you're 999, because remember our IV pumps can't read 1,000. So we go up to the next closest number, which is 999. So program your pump for that. We're going to try to do some fluid replacement. So you're probably going to have a second IV in place because you want to have a second IV in place to start running a bolus of either normal saline or LR. Probably be smartest to start normal saline, honestly, because you're going to potentially be administering blood, and we know that normal saline is the only IV fluid that is compatible with normal saline. So probably smartest to go that route. You're going to anticipate blood administration. Remember, it's not the first thing that we need to do. I think that students especially look at blood as like this life-saving measure, and this is going to take care of the issue. Well, to be honest, no, it's not, because anything you pump into the woman is going to then bleed out if you don't first take care of the bleeding process itself. So we're going to give other uterotonic medications to help that uterus contract further. So you've got that pit running. You might give some Hemorrhage. Hemorrhage should not be administered to anybody who has a past history of asthma. So if you look on their med sheet and they have Flovent, albuterol, those sort of medications on there, are obviously Advair, you're not going to give Hemorrhage to this patient. You might give them Methergin. Well, if you look on their medication record or their past medical history, or you know that this patient usually runs hypertensive or perhaps has preeclampsia, Methergin would not be appropriate because it causes elevated blood pressures. And if we're already up, we're just going to go higher. Cytotec, obviously, Cytotec we had used before when we were talking about induction or augmentation of labor to encourage that uterine irritability and those contractions. Well, how are you going to put it in a vagina that is actively bleeding? You can't. That's not appropriate. So we're going to give that rectally. And then this is the care management. This is the action plan for the state of Illinois when they put this together several years ago, within the last 10. So order, again, you have to think first things first, airway. So start your oxygen. We're going to restore circulation. So remember your CAB or ABC, however you want to do it. Look at your circulation as far as your IVs, making sure you have 2. We're going to draw labs. Are you going to draw a ton of labs? No, you're going to get a few. You're going to get just what you need. And then you're going to look at your drugs. You're going to give all of those. Trending vital signs. This is kind of down here at the bottom, and I really want to point that out to you guys who have a history of being PCTs, techs, CNAs, etc., medical aids. So vital signs are kind of down at the bottom. Why? Because we already know that this patient is crashing. What are the vital signs going to tell us? They are going to tell us that she is crashing. In the meantime, she is going to continue to bleed. So action first, then evaluate. So when we talked about putting in that Foley catheter for accurate INO, that is true. We do need accurate INO, but more so importantly, I need that Foley catheter in to relieve any kind of bladder distension, because that bladder being in place is, full of urine, is going to inhibit my uterus from contracting. So it kind of serves more than a one purpose action. And then we're going to remedy. So that's kind of, once we kind of get her stabilized, try to figure out what the root cause of this entire thing is and address it, whether it's retained placental fragments or etc. Then I have actually been able to see this. So you see this very firm fundal massage here on top, and then that the practitioner might do to try to encourage that bleeding to stop. And then down below you see, I always want to call it Bacardi, but it's not an alcoholic beverage, Baccarat balloon. And like I said, I did have a chance to see this in place when somebody was having a hemorrhage. One of the days I just happened to be down on the unit, on the labor unit. So this balloon is instilled into the uterus, the actively bleeding uterus, and then warmed preferably, but you just do what you do in a situation. Solution is like a normal saline. And so it's up to this using a stopcock, as you can see here. Look really close, and you can see this stopcock. And then the balloon is then inflated. Here's the stopcock. And it essentially does a pressure dressing upon the walls of the uterus if we're having active bleeding from the walls of the uterus, okay? The other thing I should mention as well is on the labor delivery unit as well as the postpartum unit, you guys have your regular crash carts, but then you also have your postpartum hemorrhage crash carts. So they have additional supplies, etc., for this kind of a situation that would occur, as well as the Triton that is accurately measuring that output as you saturate pad or chucks or what have you after chucks. So surgical management, if we have any arteries that are actively bleeding, you can do a surgical ligation or cauterization of those arteries. And then there's perhaps a B-Lynch procedure, which is sutures that are placed around the uterus to kind of like trying to get it to compress. I've never seen this occur. I'm not saying that it doesn't happen, but hysterectomy might actually occur more frequently because we're just trying to get the bleeding under control and get that woman stabilized. So, why is hemorrhage such a big deal? Well, I think you guys can pretty much figure it out. We are concerned about perfusion. It is an emergency. Death might occur. So first, we're going to do some of that medical management. After we've stabilized that patient, we're going to restore the circulating blood volume, depending on what the H&H is, upon the woman's religious beliefs. This is where we might be giving multiple fluid boluses, checking that H&H every 6 hours, or administering blood products. This is where we do the monitoring pulse and blood pressure, and making sure that we're keeping a very close eye on that, or delegating that off to our personnel as appropriate. So coagulopathies, this is where we need to talk about like our idiopathic thrombocytic purpura. So this is an autoimmune disorder in which antiplatelet antibodies decrease the lifespan of platelets. And obviously, if we don't have the amount of platelets on board that we think we should have, that woman is going to be at more risk for bleeding as we're not coagulating. And then von Willebrand disease is a type of hemophilia, and there's a deficiency related to that clotting protein. So does every woman that come in who has these disorders, do we already know about it right off the bat? There is a chance that we do not. It was a male patient who was in his late teens, early 20s, who had his tonsils removed, that after he had to come back into the hospital 3 times, they finally were able to diagnose him with a coagulation disorder because he just continued to bleed from that tonsil site. So he was, appeared to be low risk, appeared to have no issues, similar to many of our women who might appear, or who have had no prenatal care as well. This is yet just another treatment algorithm to help you with visualizing what we do in a postpartum hemorrhage situation. And then now we need to move on to a kind of semi-related complication of pregnancy, and that is perhaps seen in the pregnancy or in the postpartum time period, in relates to venous thromboembolism. So during pregnancy, the woman is in this kind of state of hemodilution. However, she is also at increased risk for VTE because there are increased clotting factors. Why would there be increased clotting factors? Well, if you're at risk for any kind of spontaneous abortion, your body is going to try to hold on to that pregnancy. It doesn't want you to bleed, right? So there are increased clotting factors. These continue into the postpartum time period. It's not like, your body plus, placenta is removed and boom, everything goes back to normal. Sometimes, in some circumstances, some things do. But when we're talking about coagulation, it's going to take a little time for this to come back to a normal state. Some additional reasons for that these women are at higher risk include Venous stasis. Okay, we give them an epidural. Are they out of, if it's not a walking epidural, are they going to be up and mobile and ambulating? No, they're not. If they've had a C-section, well, obviously then they're not going to be able to be as ambulatory as their friends again. Viscosities, all of that extra weight from the pregnancy, you can add up, you can have additional varicose vein development. Obesity, let's throw that on there. Advanced maternal age, smoking, more than one baby, or perhaps an infection. These all would increase the risk for a pregnant woman and risk for venous vein thromboembolism. So some signs and symptoms, you guys should already know these. We've got the unilateral leg pain, calf pain, and tenderness. We remember Holman sign as parts of your bubble heave, but we do not actually do that anymore because of the risk of actually breaking off that blood clot. Some management includes anticoagulants, analgesics, and bed rest. So then we just increase risks again. And then just obviously, we'll be discussing these a little bit further in our postoperative conversation in Unit 4, but understanding the difference between a DVT, a PE, understanding your risks for a DVT, and typically where they form. And then postpartum infections are also called puerperal infections. These are any clinical infection of the genital tract that occurs within 28 days of miscarriage, induced abortion, or delivery. And kind of look there at our differential diagnosis criteria, which include a fever, 2 or more successive days of the first 10 postpartum days, not counting the first 24 hours after delivery. So when this happens, you can have kind of different, you can have infections of different areas. So you can have, well, I'll talk about endometritis first, since that's up here first on the picture. So endometritis is the most common. It begins at the placental site and it spreads into the endometrial tissue. So anytime you have a woman that has increased abdominal pain within the first, after delivery, super tender. If we have any foul smelling, profuse lochia, fever, chills, tachycardia, uterine tenderness, they're going to be suspected of having endometritis. So Dr. Durkee, within the last year, I just heard him saying, as he reported off to a nurse, she's more tender than what I would expect her to be when I'm palpating her fundus. So I'm just going to go ahead and start her prophylactically on antibiotics. We don't want to mess with this because these women get really fatigued. They get a lot of malaise. They're not able to take care of themselves. They're not able to take care of their newborn babies. It's not a good situation. When these women come in to the hospital or to the outpatient clinic, they can potentially end up hospitalized for this infection. We're going to do hydration, analgesics, and broad spectrum antibiotics. So basically you're on, these women can have oxycodone or Norco for the pain until we can get the infection under control. And then as the infection starts to improve on day, 2 or so of broad spectrum antibiotics, well, then you should see that pain start to abate. When we're talking about broad spectrum antibiotics, these women are getting HAMP, Gent, they might be on Zosyn, they're usually on Flagyl, everything else. These women are usually, if they have to be hospitalized, they're usually there for about 4 days. It's not a good situation. So these are the ones that would come back to peds or be admitted to peds for these infections. Let's see here. Wound infection. So obviously the C-section infection can be a risk. If we have any kind of repaired vaginal laceration, that becomes infected as well. These often develop after the moms are already been discharged home. If you're at high risk, if you have obesity plus perhaps some gestational diabetes or underlying type 2 diabetes, you might actually have this patient discharged with a wound vac to try to encourage wound healing. Mastitis, this is the picture in the lower right-hand corner. So mastitis is infection of the breast. It might be a blocked duct that has not resolved. Symptoms for this: fever, pain, chills, swelling, and then redness. So usually it becomes localized immediately to one site that's perhaps, here's where it started, but then this is where it spread. So kind of like that one red localized bump that spreads very, very quickly. So for treatment, this breast looks very, very angry. You're going to do local application of heat or cold, whatever's more comfortable for the woman, analgesics, and support to the breast. So this is a boob that's going to be very, very tender. So a nice light supportive bra would be appropriate, as well as antibiotic treatment. I breastfed all 3 kiddos. Excuse me. And I didn't develop mastitis until I had number 3. And it took me down very, very quickly. Couldn't believe it. And I basically, again, talking about malaise, very tired very quickly for a longer period of time. So with mastitis, you can continue to breastfeed. We encourage you to continue to breastfeed. Frequently, this has been caused by some engorgement. So it might be in blocked duct, it might be engorgement. Well, if it's engorgement, that's the cause. Continuing to just let that breast continue to become engorged, if you're a breastfeeding mom, isn't going to result in any kind of good situation or outcome. So continuing to put that baby to breast, you can continue to feed this baby with mastitis, because now it's often caused by a blocked duct, but it's not an infection of the milk. It's an infection of the tissue. So continuing to breastfeed or to use that pump is going to encourage that milk to flow and decrease the overall discomfort, but very painful and nothing that's very fun at all. And then obviously, yet again, the woman is at risk postpartum for UTIs. I don't think that comes as any big surprise. And then the last thing that I wanted to cover here really quick is postpartum mood disorders. So the baby blues, as we know, this is related to hormonal changes, usually resolves within 2 weeks, affects over 50% of us. We do okay. Postpartum depression starts to get a little bit worse. So about 9%, 9 to 10% of us end up with postpartum depression. So if you have any previous history, for example, of depression, if you have any previous occurrences of postpartum depression with any previous pregnancies, you're obviously going to be at higher risk for this. So symptoms of this include intense sadness, labile mood swings, guilt, intense fears, anger, irritability, cravings for sweets. Again, I don't know that you would have been able to pick this really out for me because I just love sweets all the time. This is higher risk in teen mothers. Usually we treat this with SSRIs. You can continue to breastfeed with this. There's with SSRIs, that is what your desire is. And then general improvement within 6 months post-delivery. So postpartum psychosis, I have only seen once. It was during my job interview for my job on pediatrics at Swedes, and a patient who had been admitted to the unit for endometritis flipped into a postpartum psychosis very, very quickly, obviously just during the time that I was having my interview, which was about 45 minutes. During that time, the woman became convinced that the staff were taking her baby, that they were trying to separate her from her baby, and so that we could kill her baby. Obviously, this is irrational fear, but she began screaming. Her husband or her significant other was unable to calm her, and she began lashing out physically at the nurses. And actually, my interview had to be discontinued and resumed at a later time because she actually physically assaulted one of the nurses that was supposed to be in for my peer interview. This requires hospitalization. So this woman actually got transferred from the pediatric unit up to the inpatient psychiatric unit. This is going to be heavily antipsychotics with mood stabilizers. More than likely, this woman will not be able to pump and breastfeed her baby. This is not the time. You know, you guys know that I'm very supportive of breastfeeding. Like, it's a, a good thing is if we're able to do it. There's a ton of benefits to it. This is not the time. This is not the time. Um, so I have also seen women with postpartum depression who have no desire to breastfeed. And again, I'm not going to push breastfeeding on you if you have no desire to do so, because then at that point it's you know, once again, are you able to take care of your baby? Um, because you're just so upset about, like, you hate the breastfeeding process. Okay, well then let's stop breastfeeding. Goodness, aren't we glad that we have formula that is safe and wonderful, you know? So those are some mental health concerns related to, I was going to say breastfeeding, the postpartum process. Thank you very much.